صبحكم بالخير مرة ثانية، ونبدأ الجلسة الأولى اليوم، وعندنا excellent panel of panelists. الحقيقة أنا محظوظين. We have an excellent panel of panelists to discuss first session today, and our speaker, Dr. Hadi Abu Hantash. Dr. Hadi doesn't need any further introduction. He's a well-known senior cardiologist, interventional cardiologist, excellent speaker. He's the governor of the chapter of the American College of Cardiology in Jordan. What can I say more about you, Hadi? So Hadi is going to talk about keynote lecture, Jordan Heart Failure Registry, preliminary data. Dr. Hadi, please, floor is yours.
Thank you, Abu Tahir. صباح الخير. Good morning, everybody. صباح الخير مع حفظ الألقاب. اعذروني. Let me start by congratulating the organizers for the meeting, the third PCI Mena, wishing you the best of success. And also thank you for the invitation. Dr. Yusuf Abu Tariq Sadiqi, you always humble me. You never fail to do that. Thank you very much for the introduction. Chairperson. Well, we lack data on heart failure. We know that. It's not only in Jordan, by the way, it's all over in the Middle East. I was honored to have the responsibility of being the study chair of the first registry for heart failure in Jordan. We call it Jordan Heart Failure Registry, JoHFR. What we did in order to have consistency in what we do and recruiting patients, we followed the European Society guidelines, which were published in 2021, which you're all aware of, in terms of how we define heart failure. The algorithm we used is also the same which the European Society in those guidelines 21 advised us to do. And please focus on how we do it. If you suspect heart failure, you need biomarkers. If the biomarkers which you have are not available to you, you need an echo type of structural abnormality, and then you go down the algorithm of diagnosis. All of our patients which we tried to recruit, we encouraged all our colleague investigators to make sure that biomarkers, 12-lead EKG, transthoracic echo, chest X-ray, and blood tests including CBC, kidney function, thyroid, fasting sugar and hemoglobin A1C, lipids, and ion status with transferrin saturation and ferritin included in the chart. So, we are intending to recruit 4,000 patients. I'm not sure we will reach that, but we're already there with 1,500 patients already. The major objective of our study is to obtain a reliable estimate of the rates of cardiovascular death and hospitalization for decompensated heart failure, with secondary outcome measures looking at worsening kidney function compared to baseline estimated GFR. We posted that in the clinicaltrial.government in 21. We started recruiting in the summer of 21, and it's already included in the National Library of Medicine in the United States. Now, who is eligible to enter the study? Anybody, male, female, above 18 years old, who has heart failure as defined by internationally recognized guidelines. And to simplify it for our colleagues, we made it the European Society guidelines. Now, those patients, we kind of recommended to have them residents of the Kingdom of Jordan to make sure that we can follow them up. If you cannot follow them up and you know that, don't include them. That's an exclusion criteria. And of course, the patient has to be able to sign a consent form. Let me just express my great appreciation for all the hospitals, all the PIs, everybody who was involved in the study, including medical students, residents, everybody who contributed. I cannot tell you that I won't be standing here in front of you if it were not for your help. Special thanks goes to Professor Yusuf Khadr Qaoud, who really relentlessly helped us out getting the data together. Dr. Mahmoud Zouek really did a very, very hard job in terms of recruitment and coordination of the study. And Dr. Ala Bani Hamdan, I'm not sure she's here, who from the inception was also of a great help. So, do we have data in the Middle East to guide us through? Yes, we do. If you look here, 1, 2, 3, 4, 5, these are Middle Eastern, compared to the ADHERE from the United States and Registry from the European Society of Cardiology. What do you find? You find that the mean age in the Middle East is about 10 years younger than the States and Europe. Females are more represented, like 50% in the States compared to 1/3 in the Middle East. Diabetes, we are diabetes region here in the Middle East, very prevalent. Hypertension tops the prevalence of comorbidities. And atrial fibrillation, and I cannot explain that. I really can't. Why is it in the double digit, anywhere from 10 to 24% compared to higher, which reaches about 44% in Europe? I don't have a good explanation. The median ejection fraction, which was included in the study, anywhere from 35 to 40, and in those studies, I mean. What really is also interesting, HIF-PEF, look at HIF-PEF, is a bit underrepresented in the region. Now, the Gulf Care Registry showed almost the same comorbidities dominant by hypertension, diabetes, and coronary artery disease with less frequency of atrial fibrillation. And there is an underrepresentation again of heart failure with a preserved ejection fraction. What are the heart failure registries from the META, not the MENA region, including Turkey, of course? What's common in those registries, and we have the Jordanian Heart Failure Registry, which is ongoing. I present to you the preliminary data, and my friend Hadi Abu in the Lebanese Heart Failure Registry also, which is still ongoing. There is a high prevalence of comorbidity. Ischemic etiology is the dominant etiology, and there seems to be a 10-year younger type of prevalence of patients. So, here you are. I will present to you the interim analyses of 850 patients out of 1,300 patients recruited. Let me start with this slide. Well, in Jordan, females seem to be a bit more represented compared to the rest of the world in the Middle East, 44%, males 56%. The age distribution is kind of fascinating. We have patients from 18 years old, and the eldest recruited was 94 years old. The mean age is 66. What's that telling me? With a standard deviation of 9 to 12. Are we really that younger than the whole of the world in terms of diagnosis? I'm not quite sure. I'll wait until we get the rest of the data. In terms of risk factors distribution in those 850 patients, look at this. Hypertension predominates, 73%. Diabetes, unfortunately, 60%. Smokers, Dr. Firas Al-Hawari outlined how big of a smoking issue we have in Jordan, about 30% smokers. And look at overweight and obesity. This is really striking when you think about it, right? About almost 73% of our patients are either overweight or obese. And I cannot explain this. Dyslipidemia, I think my take on this, so that you don't ask me the question at the end, is probably because of the way the dyslipidemia was defined in our protocol. It was not defined by guideline, age category, risk factors, etc. Chronic kidney disease was there in 16%. So how did the patients present when we recruited them? 71% had a chronic heart failure because they had already established diagnosis of a chronic heart failure, and 29% were with acute heart failure. De novo, new ones, naive patients were only 22%, and the ones with established heart failure, 78%. Now, what is the etiology in those 850 patients. Ischemia, ischemic coronary artery disease, prevalent, like the rest of the world, like the rest of the Middle East, 64, almost 65%. The non-ischemic etiology was 35.3%. And I think that's a relative alarming for everybody in the room. We still have ischemic coronary artery disease as the predominant etiology for advanced heart failure. How do we do in terms of following biomarkers? Biomarkers are recommended as a class 1A in the diagnoses of heart failure. And what I can tell you that I'm a bit nicely surprised to know that out of those patients which we are presenting today, 28% had a BNP, which was there in the chart, and look at that, 97.5 had it above 35 picogram. That's by definition of the European Society, by the way. Okay, the European Society put this cut figure, the cut number, 35. Anti-proBNP, again, you look at 93 almost % of the patients who were included. So we are doing well in terms of who we are including in the study because they have heart failure. They have the real heart failure. And I'm proud to know and present that 53% of all our patients already have a biomarker in the chart. And hopefully, when I present the final, hopefully they will reach more than 90%. Compared to the Gulf Care Registry, well, congratulations to our local cardiologists, actually. Look at that. They checked the proBNP in less than 25% of the patients. We did fine. One striking thing which might be interesting, cardiologists tend to order the biomarkers at 71% compared to internists who have it only at 29%. Interesting how the internists and the cardiologists look at the biomarkers indeed. The European Society of Guidelines divided heart failure according to ejection fraction. How is that divided in our patients? Like all the rest of the world, about 65% had heart failure with reduced ejection fraction, HFrEF. However, heart failure with mid-range was present in 10.9%, and heart failure with the preserved ejection fraction, which is above 50%, was about 25%. So if you look at the older definition of HFpEF, we almost have 35% with HFpEF compared to HFrEF. Interesting. Mitral regurg. How was it documented in our charts in the 850 patients? 40% did not have mitral regurg. The rest had mild to moderate to severe. It's an important item, of course, in heart failure with advanced symptomatology because of the structural heart disease intervention which we have now with mitral clip, etc. GFR, estimated GFR. Interesting to know that only 20% of the patients included in the study had a normal kidney function, as defined as normal, which is above estimated GFR of 20%. And we have stage 1, 2, 3, 4 here, which is well represented too. It's not 2 minutes, it's 2:30. I can watch it. I'm good at this, don't worry. The creatinine distribution, when you look at the abnormal creatinine, it was, if you look at it as above 1, was there in 2/3 of the patients. Unfortunately, this slide tells me that there were anemia in 57% of the patients. 43 did not. I did not have the exact numbers to give you the ferritin and the transferrin saturation, which you all know that iron intravenous treatment for those patients who remain symptomatic in spite of maximum guideline therapy is indicated. Maybe next time I will have it for you. How did the EKG rhythm and the QRS morphology showed in those patients? About 47% had a normal EKG. AFib, again, I really don't have a good explanation for that. You can help me with that. 9.2% only. I don't know what that means. I'm not quite sure. I believe that this is a real number. We'll wait until the end of the recruitment, I guess. Left bundle 5.7, right bundle 2.7. Why did I outline that? Because the percentage of those patients of less than 8%, those are the patients who remain candidates for CRTD for patients resistant to treatment, of course. This is a good slide, which took us a while to get out of the numbers. How did we do in terms of using medications? The 4 pillars, everybody knows about them by now in 2022. Well, 73% were using beta blockers. Wonderful. 77% used RAS inhibition. You look at this. ARB 24%, ACE 19, aldosterone antagonist 22, and ARNI Entresto 12.7%. We're doing well in terms of following up guidelines. SGLT2 inhibition 6.4, I promise you this number will jump more after our more common users of this. Let me finish. I have only 20 seconds. I proposed last year, and I proposed this year. And I'll keep proposing that until it happens. We need to have a Jordan and hopefully a Middle East cardiovascular research group, which can combine the efforts of which we do locally and regionally in doing cardiovascular research. It's not an impossible dream, and I'm sure we can reach there. With that, I'm right on time, my organizer. Thank you all for being part of this national project. Thank you to the chairpersons.
Thank you, Hadi, for being on time. You have still 10 seconds more. You can talk. I commend you and thank you for an excellent talk. And I agree with you. We need more research and more local studies in Jordan. Next speaker, our guest of honor. She's the only lady from our brotherly Arab countries, and we are proud of you, Mirvat. Mirvat Alasnage is the director of the catheterization lab in King Fahd Armed Forces Hospital. And she's on the board of the SKY in the States. I heard last PCR in Paris, she was on a panel. She shared with the panel excellent speakers on interventional cardiology. We are proud of you, Mirvat, and you are most welcome. Please proceed. The floor is yours. And she's going to give a keynote lecture, Two-Stent Bifurcation Strategies. Dr. Mirvat, please.
Well, thank you for the introduction and the invitation. Certainly a very warm welcome in Amman, and I'm really honored to be amongst you. Just on behalf of SKY, the Society of Cardiovascular Angiography and Intervention, I think this is a great initiative and hopefully more collaborative projects to come. So I was tasked today, and very quickly I'll try to stick to my time to discuss bifurcation strategies. I know this is a topic that's becoming very popular in the interventional community worldwide. When we look at the background of bifurcation stenting, 15 to 20% of all PCIs do involve some kind of a bifurcation. Some of the most challenging PCIs involve bifurcations. They're usually associated with more procedural complications, higher restenosis rates, stent thrombosis, etc. And so we do need to refine our technique. Abrupt side branch closure and side branch osteal restenosis are common difficult or challenges of bifurcation stenting that we need to be cognizant of. And optimal management is still subject of continued consideration in the literature. There are different two-stent bifurcation technique, whether it starts with a provisional or stepwise provisional strategy, followed by TAP, T, DK crush, nano crush, culotte, etc. These are all techniques. But when we look at the multitude of trials that have actually been published, they show a lack of benefit with a systemic two-stent strategy, whether we're talking about the Nordic trial, BBC1, Cactus, etc. But even with true large bifurcations, the EBC2, EBC main, and so on have all suggested that a provisional strategy should be the default. and outcomes tend to be worse with a more systemic dual stenting strategy. And we can see it here from this Nordic and BBC meta-analysis. So when we talk about true bifurcations, we're really talking about Medina 111, 101, and 011. These are the typical bifurcations that involve both branches. And those are the ones that we do need to start considering whether a two-stent strategy upfront is the ideal strategy. But we need to understand that when we talk about bifurcation lesions, we're not talking about two tubes alone. We're talking about, yes, the main vessel, we're talking about the side branch, but we're also talking about a carina and a area of confluence, which often dictate how we proceed. So although we call it a side branch, the side branch is critical in the decision-making of which strategy we actually take. And many have strong reservations about calling the circumflex coronary artery, for example, a side branch, because sometimes the circumflex is not a negligible vessel, particularly if it's large and dominant. So the advantages of pre-dilating the side branch, well, if you have osteostenosis that is significant, it may help you wire and so on. Extensive calcification can be treated prior to stenting. Increasing and facilitating rewiring, as I mentioned. Suboptimal flow after wiring can be avoided with dilatation. But of course, the disadvantages of tackling the side branch up front is dissection, which may eventually force you to stent the side branch that you may have not considered initially. And restenosis at the side branch, particularly if you don't have adequate scaffolding. But how do we decide between an a priori two-stent strategy versus a stepwise? Well, a small number of bifurcations actually do require two-stent. The majority, you can actually go with a provisional strategy. However, when you do consider provisional, you do have to have plan B. Up front, you have to recognize that what am I going to do should I need to put in a second stent? Which means up front you need to determine which strategy you want to adopt. The use, unfortunately, of IVAS guidance is very low in the bulk of studies, including left main studies, which often can help guide us. And the experience of the operator is critical here because it requires a lot of skill to wire, rewire, but also judgment. This is actually a publication that my colleague and I, Dr. Mamas, some of you do know him, where you look at the options. When you're doing a provisional stepwise strategy, if you do decide to move on to a two-stent strategy, unfortunately DK crush is not an option, right? Because DK crush, you stent the side branch first. Your options at that point in time are either tap and T or a culotte technique. The criteria really based on definition 2 are 1 major and 2 minor, where you look at the length, you look at more than 10 millimeters of stenosis, more than 70% in left main, and non-left main more than 90% stenosis. And then the minor criteria include bifurcation angle less than 45 or more than 70, main vessel less than 2.5 diameter, and the side branch needs to be long and also more than 2.5, more than 10 millimeters and more than 2.5 in diameter. But also if you have thrombus, CTO, calcification, and so on. So when we look at the angulation between the main vessel and the side branch, as it approaches 90 degrees, as it comes close to being perpendicular, that's when your T or tap stenting becomes more ideal because you're able to adequately cover both shoulders and scaffold both shoulders with your stent. As it becomes narrower, you are less likely to be able to perform complete coverage with something like tap, and you're probably better off with a culotte or something like a DK crush. Stepwise provisional, these are the basic steps. I don't want to bore you with them. They're available everywhere. This is a simple example of a patient who had a bifurcation LAD diagonal. We stented the LAD while the diagonal was protected with a wire, but as you can see here, the flow is severely impaired after stenting the LAD and optimizing it with post-dilatation. And at that point, we had to rewire. Now, when you do appropriate post-dilatation, it actually facilitates recrossing into the side branch. And a lot of us tend to keep the side branch wire in position just so that we can use it as a marker. We try to keep a shorter length of the wire that is trapped between the stent, kissing inflations, and then you can reconsider whether you want to put a tap or a second stent, or not. Ideally, you want the best angle. So, for example, the areocranial is not going to open up that bifurcation adequately. You probably need a caudal view like an LAO caudal to help position your stent in the side branch, maintaining a wire in the main vessel. And once the deployment is done, as you can see, you have to do a proximal optimization and stay clear of the neocarina. And so this was the final result in this particular patient. So again, these are the TAP steps. Once you've already stented, you rewire. POT helps you with the rewiring. You rewire, you balloon, you reassess, and determine whether you want to stent or not. This is what it actually ends up looking at in a model, the neocarina that you have created, but actually looking at what kissing balloon inflation does. The data is there. Unfortunately, much of the data has been rescue or salvage for TAP technique. So we don't actually have a lot of data where TAP was an upfront strategy. And hence, a lot of the outcomes are actually in terms of stent thrombosis, target vessel revascularization, and so on, are worse with TAP technique compared with the other techniques, but that is the caveat. Again, this is an excellent video, but I'm not going to bore you with the details of how it's done. But ultimately, this is what you want, is adequate scaffolding of both arms. Sometimes modeling has been done, and we've tried it with our group, where you can plan and strategize with your patients. But very critical is that you understand where to put your POT balloon, staying away from your neocarina when you're using TAP in particular. Again, this is what your ideal POT technique should be. Ideally, when you're doing POT, you want to size it to the proximal vessel because your stent is sized to the distal reference. And so you do need to make sure that your proximal segment reaches adequate size. Again, there are simple models that have been published in the EBC main, and you can see how it's done. Culotte, again, there are several data published since 2009 onwards that are showing the outcomes, which are not bad. As a matter of fact, the Celtic trial was published. It was one of the more recent trials, published about 4 years ago, again showing fairly equivalent results. And with this particular trial, they did the bifurcation using radial access in more than 96% of the patients and so on. And so actually, bifurcation techniques can be done fairly smoothly in expert hands. Once again, this is a video that actually shows you that what you do is once you've done the main branch and you have a significant overlap with the side branch, proximal optimization once again is important here. Kissing inflations, sequential is what's being shown in this video, and a final POT. And what you actually, and this is the final POT, once again staying away from the metallic neocarina. And what you do see when you look at it in 3D modeling is you see a significant overlap of the metal. And yet it's all well opposed and expanded in the main vessel. This is what a culotte is. It looks more like a trouser. Again, not to belabor the actual technique, but the steps are actually published in several documents. This is an example of a new technique, which is culotte, and a variant of culotte, the more recent variant, which is DK culotte, where we've added another kiss here. So this is a patient who had ostial circumflex disease. Once again, what we're doing is wiring both vessels, dilating the side branch, recrossing with a stent, making sure there's adequate overlap into the left main. Remember, if your left main ostium is okay, you don't need to stent all the way back, but you need to have enough room to do your proximal optimization. And once you've actually done kissing inflations, this is, you can see the vessel en face. And you can see that rewiring becomes much, much easier when you do your proximal optimization, as it is the case with all techniques. What we tend to do is go into the main vessel, pull the wire back, just so you know that you're not under any kind of struts. But that's what the proximal optimization does. It facilitates rewiring. And then it facilitates the crossing of the balloons. And you can see here that the balloons cross very well once you've been very meticulous about your kiss and about your POT. What you do want is minimal protrusion into the confluence, and again, sequential inflations and moderate intermediate pressures. And again, you can see in this top left panel, you see the en face, you see the stent in the circumflex coronary artery, you see the sequential inflations, you see proximal optimization positioning in the stent boost, and the final results. DK crush, there have been significant variations in the DK crush and developments. It went from classic crush all the way to mini crush, all the way to DK, and now we're talking about nano and a DK nano and so on. The trials for nano and DK nano are not there yet. What we do have is DK crush data that's largely coming from Korea and East Asia. We started with the DK Crush 2, which looked at DK Crush compared with provisional stenting, DK Crush 3 that looked at DK Crush versus culotte in distal left main, and again DK Crush 5, which looked at DK Crush versus provisional with distal left main. There's significant outcome differences between DK Crush 5 and the EBC main, where in this one it concluded the DK Crush was superior at 12 months compared with the EBC main. Is it that operators in Asia are more competent with two-stent techniques? Is it that the patient substrate is different? We really don't know. What we do know is that they were fairly equivalent, except that in DK Crush 5, you looked at the syntax score was in fact higher, but the IVUS adoption in both techniques, in both studies, was approximately 40%. Again, the steps, I'm not going to belabor our audience with it, but they are available. And perhaps this is important to see what happens with DK Crush. This is a model, and thanks to the University of Minnesota for providing me with this. But basically, when you do adequate crush, it facilitates your recrossing, and you can see it here when you see the metal being crushed appropriately, as opposed to when the metal is not appropriately crushed. So when you get partial crush, it actually makes it difficult to rewire, but when you do an optimal crush, it makes your rewiring a little easier. So you see this is not adequately crushed. I'm going to try to move it over here and try to show you when they take a balloon and now do a better crush, it facilitates the rewiring on the model. And I think the models are perhaps the new era of learning for our younger colleagues and fellows in training for complex procedures. And you see here, this is a much better crushed stent with a 4.0 balloon as opposed to the one previous, and it facilitates the recrossing of all your equipment subsequently. So again, this is a cartoon that shows it, but this is a patient who had distal left main, but actually tubular left main stenosis and osteal disease that was evident in both. And what you do see at the end is stenting of both vessels using DK Crush. The reason we opted to do DK Crush in this particular patient was the wiring of the side branch, i.e. the circumflex, was difficult. And so we felt upfront we want to secure that vessel. Again, this is on the AHA website. You can find the different techniques, be it DK Crush, tap, provisional, etc., and it has some cartoons that are easily usable. I think the important thing here is that a lot of us are afraid of crushing, when in fact crushing helps you re-access your side branch, and inadequate stent expansion in the main vessel, because that is really how you get optimization and you reduce events. Do we need to do kissing balloon inflations? Again, for the sake of time, I'm going to tell you, there's no penalty for doing kissing balloon inflations. It may actually give you access to your side branch, particularly a significant side branch, subsequently, and there's no penalty in terms of increased events. Again, there are different techniques of how you want to do it, but if you look carefully at my arrows here, when you do a good kissing inflation, you end up scaffolding the side branch very well. And so you may end up requiring just a single stent technique as opposed to a two-stent technique. And the same thing with pot. There's no real penalty for pot, but you get adequate optimization, and that's what you see when you end up doing balloon intracoronary imaging. So I'll stop here and thank you very much for the opportunity to present.
Dr. Mirvat, thank you very much for an excellent talk on a very difficult and intriguing subject in interventional cardiology. We'll keep the questions to the Q&A segment. Now I'll hand mic to Dr. Hatem Al-Abbadi. Hatem was my student, then colleague, and now he is our chief president of the Cardiac Society, and in future, inshallah, Minister of Health, بس بعد يوسف إن شاء الله. فتفضل.
Thank you, Basha Abu Tariq, my boss, who taught me the letters of the cardiology in the 1996 and after that. هذول الرواد اللي حكينا عنهم اللي علمونا مبادئ القلب، دكتور يوسف واحد منهم، كان أهم واحد منهم طبعا. Okay. When we speak about intervention and left main intervention. As we are an interventional cardiologist, we can put stent anywhere and everywhere and anytime. But before we put stent here and there is a patient, there is the age of patient, complications, age. We should consider all these factors. Putting a stent in diagonal branch and putting a stent in obtuse margin branch and bifurcation LED diagonal, bifurcation circumflex open is not like doing left main bifurcation. We can do it, but we should consider the indication, the prohibitive factor, the contraindication, the age, the complication. So it is very important. Till now, left main treatment is surgical till now. But with the advances in the interventional cardiology and the extreme cautiousness, we can put stent by taking the agreement and lessons from patient. Here I want to welcome Dr. Amr Al Karmi, who is interventional cardiologist in Jordan. He will speak about left main bifurcation, dip and non-ST elevation in my left main bifurcation. Dr. Amr Al Karmi, welcome.
Morning, everybody. And this case was, I think, I can't remember, either first or second day of Eid. So it's about a 63-year-old gentleman who is a tourist and known history of hypertension, diabetes, heavy smokers, and heavy alcohol intake. 7 months prior to his presentation, he had a complex PCI with multiple stents. He was told that they'd done a complex PCI and he had to have a second session, which he didn't turn up to. He had a surgical turn down at the time because he had a bilateral carotid artery disease. So in the hotel in the Dead Sea, he had a cardiac arrest, resuscitated by the doctor in the hotel, was transferred to Mustashfa Shune, which is a little hospital next to the Dead Sea Resort. And at that time, he had a broad complex tachycardia. He received too many shocks, was given amiodarone, magnesium, potassium, and we decided to take him. And he arrived with a blood pressure of 90/60 on inotropes with a heart rate of 130, slightly hypoxic. On our arrival to our hospital, this is his ECG, which showed some ischemia, some AF, but nothing massive. And at that stage, we decided to stabilize him as he was in a pulmonary edema. He was given Lasix infusion, optimized his inotropes, stabilized. His echo showed moderately impaired LV function due to inferior-posterior hypokinesia with moderate to severe mitral regurgitation. Stats improved slightly, but he started to have sustained VTACs, required a few more shocks in our ICU with the new ECG changes, so we've decided to take him to the cath lab. We went through the right radial artery. We prepared the femoral just in case that we needed a support device, airway support, and cardiac surgeon on board. Okay. So this is the first angiogram which showed severe osseal stenosis of his osseal stent, circ stent, and there is a disease in the stents in the OM as well. I can't move this. Looks like he had, so that's more the other coda view, and we showed as well here that there is a slight abnormality in the osseal LED stent with some disease in the distal left main, which we'll show in another view in a minute. This is his right coronary artery, which I think that's the one we've been left at the first PCI for a second session. And just that's a view for the osseal LED and the distal left main. Sorry, it's not loading. There's a problem there. Okay. The rest of the stents in the LED looks okay. There's osteal-diagonal disease. So at this stage, there was the discussion. Patient was unstable. He's on a massive dose of inotropes. He had a complaint of ongoing chest pain. Surgeons, high risk for surgery, as he's in acute shape, and already been turned down for elective CABG due to the severe carotid disease. We elected to go for a complex PCI, upgraded the radial to 7.5 sheetless guide, and initial plan, I was just to keep it simple, just to do a DCB to the ostial circ, stabilize the patient, get him back to our ICU, and then sort out the carotid. In a few days later, just we can go for an open heart for a CABG and mitral valve repair or replacement because of ischemic ventricle. So basically, the idea of the DCB, if you go with non-compliant, 1-to-1, very high pressure, and this is the DCB, and at this stage, there is not a full expansion of the ostial circ, but the flow is better, but we notice that there is a plaque shift towards the ostial LED. And at this stage, we've decided to go for an IVUS. Unfortunately, the IVUS is not loading as well. But the IVUS showed the whole complete of undersized, underdeployed stent from the OM back to the ostial circ and severe instant restenosis in the ostial LAD and in the distal left main. Actually, the stent is extending to the left main, which not clear on the imaging is clear. On the angiogram, it's not that clear. So I went from distal to proximal with aggressive pre-dilatation with non-compliant balloons and DCBs. Same with the LAD, very aggressive pre-dilatation and a DCB. And then I potted, and this is the final results. The patient had a bumpy admission, so about 3-4 days with sustained tachycardia, but settled eventually. The EP guys actually decided to put an ICD in him, and we discharged him eventually with a plan to come back for his carotids and for his eventually bypass surgery, but he didn't show up. I had a phone call after 3-4 months saying that he's coming to Amman to have his surgery done, but he never showed up till now. Right, we're done. The idea of it is the role of DCB. Is it, can you cause for as a primary intervention? The role of DCB, you can stop the antiplatelet much earlier if you're planning for an urgent or emergent surgery, so you don't have to keep the patient on longer on Plavix. You can stop it within 15 days. We started actually to use DCBs in a lot of de novo lesions. We have a really good series at Prince Hamza Hospital. We're still running the trial, or the study, but we've got about 180 patients with 300 DCBs in de novo lesions, and they're doing quite well. So the more experience with DCB, actually you start to use it more even and you get braver. So when we started to do them on the side branches, trying not to interfere with the main branch or the main vessel. But now actually we are quite comfortable to do it even in proximal LED lesion, de novo, and leave it. First impression, that's always you get worried about when you get dissection with a DCB, whether you should leave it or stent it. And that's the rule of doing 1-to-1 with non-compliance. So if you don't get dissection, you are free. But even if you get dissection and it's a TIMI-3 flow, you leave it and the patient is quite well. But it's with experience and you get braver and braver with it. And you consider that it's a less metal For side branches, I find it really, really, really nice because you don't have to do a lot of metal. But if you want to do the DCB in a side branch, do it first before you put a stent in. Right hip. You want me to show you a bit of data?
Thank you, Dr. Amr, for this nice presentation. And the floor now open for the discussion, please. Yusuf.
Thank you for the talk. I just have a question. I know we're trying to avoid drug-eluting balloons in acute MIs, NSTEMI, non-STEMI, because of the thrombus burden. You need that balloon to be really exposed to the wall of the arteries so you can have a fast homogeneous uptake of the drug elution. And my other take on the case you just presented is, did you put a balloon pump? I mean, this guy had an arrest.
You didn't need it. We just were quick. After we opened the offsets, just stabilized this.
I mean, whenever you have a severe MR, I honestly think you do need a balloon pump because
just in case that we need it, but we didn't need it.
you need it for the circulatory support of the patient while you're doing the procedure. How was his pressure during the?
When he got into the cath lab, it was about 90/60. By the time we opened the labs, just went up to 130.
And the
the
3-hour window, was that the transportation or he was in your
When
place?
he came, it's not an ST elevation. When he came, he was in pulmonary edema and he was more stable. So we just went with just to offload him with amyletics and more inotropes.
Yeah, I mean,
he
but
was stable.
this guy was shocked 20 times. I don't care if he has ST elevation or not.
But if you give yourself, it's not an emergency. If you allow yourself about 2 hours to offload the patient, you will make much better outcome.
I honestly disagree with that.
If you take him with pulmonary edema and you ended up intubating him and all this, he was not intubated. And you intubate him and you increase the risk. While if there's no ST elevation, an hour or two of offloading him will save you a lot. Now I agree with you, thrombus burden, but a lot of non-STEMIs actually, there's not a lot of big thrombus. And actually you can go for it. But if you get big thrombus, I can take your point that you won't expose it to endothelium, to the drug. But if there is no big thrombus burden, you just can go. It's not a big thing. And a lot of STEMIs actually, you got no thrombus. I haven't done it in STEMIs yet, but I'm getting more brave. I'm trying to be more brave to start using in STEMI patients. But I haven't used it in STEMI patients yet.
Congratulations on an excellent outcome. A general question for you, if I may. What is the status of percutaneous mechanical support for patients who are in a hypotensive cardiogenic shock? Are we practicing that?
I mean, the only thing we've got in Jordan is balloon pump at the moment. And balloon pump is not a great tool anyway. ECMO is available, but with a lot of difficulties or expensive. Now we got, I think in the next few months, we're going to have a device which is similar to Impella. It's coming to the market now.
Thank you very much for a very nice session. Actually, I have a question for Dr. Amr and a question for Dr. Mirvat, if you allow for us. So the first question for Amr, I think the problem in this, from the beginning, that it was mechanical problem with under-deployed stent. So the result was expected. So putting the stent or correcting the position of the stent and allowing it to have the natural way of endothelialization, proper endothelialization is the accurate way. So do you think just correcting it by NC balloon, because it is just deployed, the DEB, it is not for a long time ago, and just correcting it and confirming that it is well opposed, well deployed by doing IVUS, even after finishing the procedure, would that be enough without doing further?
In theory, yes. I mean, before before the drug-eluting balloon, that's what you used to do. I mean, and we know the data of non-compliance in STEMIs, in stent restenosis, and it's acceptable treatment. We know all that. But when you talk about 7-month-old stents, so there's no drug literally on it. So whether that will keep you more comfy, you just put a drug in and get out. I can't take your point, but I'm a big fan of DCBs. But basically, yes, I can take your point of doing just non-compliant and walk out. And but delivering a drug it's make you more comfortable with the OSET circ and left main.
Yeah, that it's mechanical problem. It's not a chemical
it is deployed under side stents.
My question to Dr. Mirvat, if you allow for me, I don't know if she can answer. Yeah, Dr. Mirvat, while you long time, while you Mirvat. I know her from Saudi Arabia, so I know her very well. Dr. Mirvat, now we have studies. We know before that professional stenting with 1 stent bifurcation is better than 2 stents. Now we have studies showing that 2 stents, whatever technique you use, is better than 1 stent. How do you comment on this?
Well, I think the bulk of the studies actually do suggest that the event rates are higher with 2-stent strategies compared with single-stent strategies. So I would still say a default strategy of provisional is more ideal. I think only some of the DK crush studies have shown superiority of an upfront 2-stent strategy compared with some of the other studies, Celtic, etc., that looked at culotte and showed not superiority, but no increase in events. So I would still say use judgment, be minimalistic in terms of the number of stents that you put in, and honestly, don't do 2-stent bifurcation complex procedures if you don't have the expertise. Refer it to somebody with the expertise, because in my experience, it's harder to fix a botched 2-stent strategy than restenosis or something in a side branch in a single stent.
You don't do exceptions for that if you have diseased side branch?
No, we do. I mean, there are cases where you start with the side branch. You start up front with 2-stent strategy, especially if there's disease in the side branch that is more than 10 millimeters in length. Yes. The side branch is more than 2, and it's
2 stents better than 1
Correct.
stent. Yeah, thank you.
Can I just make a quick
Only
comment
the side branch,
about this? Allow me to make this comment. Beautiful, Mirvat, for the presentation and the discussion. Regarding this point, there was a study which I think it was one of the most elegant which came out from Southeast Asia, looking at distal bifurcating stenting technique. We all know that ostial circ, like your case, is the Achilles heel of doing 2-stent techniques when you have distal lift main. We know it's the ostial circ. Most of the time they come back with ostial circ restenosis. Now, what they looked at, they wanted to see if by IVAS guidance you can predict failure of your provisional technique and going with 2 stents technique immediately. And with IVAS guidance, what happens, and this is a very good study, and I'm sure maybe you will enjoy it, I'll share it with you. In that study, what IVAS criteria showed, if the ostial circ cross-sectional area is less than 3.9 millimeters square, and or there is a calcified nodule sitting there, and or there is a layered atheroma in the IVAS, then don't do provisional, do 2-stent techniques up front, because they can predict that the ostial circ will come back with instant restenosis. So thank you for allowing me to make the comment.
I mean, the ostial circ is always the problem, as you said, but it's not all about stenting it. It's about the sheer stress. I mean, Mirvat showed the British used to use it to say it's a triangle of death, which is that carina, just that angulation before the main vessel with the side branch. And that's usually where the problem is. And because whatever you do, it's a metal, which is cylinder, doing it in a tubular artery.
Please.
So whatever you do, there is always that shear stress on that angle.
Please.
Go
Thank
ahead.
you for the presentation. I'm asked to Dr. Hadi, please, about heart failure. What is the indication of anticoagulation in patient with heart failure without AF or valve problems? The second question is there a role of stem cells in treatment of heart failure now? Thank you.
I'm sorry, I missed the second question. What's the second question?
Is there a role of stem cell cells in treatment of heart failure now? Thank you.
I'll skip answering this, but the first question about anticoagulation, heart
In
failure?
patient with heart failure without EF or valves problems.
Okay, that's a
Is there
very good
indication or
question.
not?
The only indication in heart failure patients, and correct me if you know better, in the guidelines to have anticoagulation, if you don't have AFib and you don't have another valvular indication, if you see a mural thrombus sitting in the left ventricular apex in somebody who has an aneurysm. Otherwise, I don't know of any other indication. Mirvat, do you know any other indication? Sorry? No, you do not give oral anticoagulant by ejection fraction. You don't have to do that. Patients may have 10% ejection fraction, and you can see smoke on your transthoracic echo, but that's not an indication, unfortunately. Sorry? Smoking is not what you need to see, not smoking. Smoke on the transthoracic echo is not, it's not really a good indication for that. Regarding STEMI, I think Dr. Latouf has been interested in those in the past, Amr, giving patients stem cells for patients who suffer from heart failure and trying to regenerate the myocardial cells. I'm not quite sure that there are common type of practices anywhere in the world.
It's all investigation.
Hadi, I'm sorry, I cannot hear you well. I cannot hear you well for the important question that you are asking. But now that I have the floor, I have a question for you, because you have brought up a very important point. The talk that you have presented is truly world-class. Congratulations.
Thank you, thank you.
You concluded that by saying the time has come for Middle East cardiovascular group. Of everything that you have said, that's the one thing I'm going to remember, and I hope you will act on that, because that is really a strategic objective that should not be ignored, and I wish the society would adopt your proposal and take that forward, because that would be a fantastic achievement for such a society to be born out of this meeting and out of Jordan. I congratulate you, Dr. Hadi, for putting that forward.
Thank you, Dr. Amr. Please.
بدي احكي بالعربي احسن مشان سنه 88 عملنا اول جوردان كاردياك سوسايتي ميتينج، واتفقنا في شهر 91 في مصر مشان نعمل الميد ايست كارديو سوسايتي اللي تفضلت فيها. كان الفكره، وب2/8/90 عرفت شو صار بالكويت وتفرقعت الأمة العربية من يومها. فيعني ولا الفكرة موجودة من 30 سنة.
Dr. Yusuf, I was at that meeting which you presided over, والدكتور محمد الفقيه من المملكة العربية السعودية was elected as the next
مؤيد
president.
السابق.
That's right.
The proposal, Dr. Amr, thank you for your humbled words which you gave to me. Amr, I totally agree with you. The time has come where we locally and regionally have to join forces. Why is the United States on top of every part in the world in research? The United States, it's 51 states. We can get together and be as strong. Yes, they are less strong, but we can be more effective in doing that. But thank you. Thanks, close.
Hadi, sorry. I have Hadi. Thank you. It's here. On your right.
Yes.
Thank you. I want to thank you for the elegant presentation. As always, you are a good speaker. But I want to ask you about the incidence of AFib. And I was whispering Munir that the population in the United States and Europe is older. And do you think this is one of the factors? Because as you grow older, every decade will add certain percentage of AFib incidence. The other thing as you know, in the States and in Canada and Europe, they are more meticulous in looking for incidence of AFib and heart failure, including loop recording and so forth. So do you think those two factors? Thank you.
A brilliant point. Yahya and Munir, of course, sitting next to you. I think this explains part of it because, in the United States and Europe, the incidence of AFib was higher in patients with heart failure. So thank you for alerting me. It might be the age factor. I'm not sure, but it might be. So that's a good point.
It's the most common.
No more
Thank you very
questions.
much. Congratulations for this third Mena PCI, and congratulations for my dear friend Dr. Mahmoud Zreik for this very big achievement for the successive years. I know Mahmoud previously, and when he is insisting on something, he will do it. So he will do better in the future. And Dr. Hadi, don't mention that the innovation, how to do the Middle East research group, we discussing this with Mirvat and Dr. Hadi before a few minutes. I have some comment and short questions. I think Dr. Amr, for the guideline to use the drug-coated balloons, the only indication or the clear indication is in the ISR. So it is a class 1 recommendation in the treatment of diffuse or significant ISR. There is no clear data or evidence base for the big trials to use these in STEMI or non-STEMI or in a big thrombus bed, and this is for my knowledge. Another important related question, comment that as Dr. Hadi said, the ostial circ ISR or disease is a malignant disease. So always for the interventionist, the ostial circ is a malignant disease. Second question to Dr. Hadi. It is strange for me to, very big achievement in the JoHFR trial, but it is strange to find a completely normal ECG in a significant heart failure patient. You found in your data that 50% of those patients with heart failure with reduced ejection fraction or maybe preserved ejection fraction, this is a note which is pay attention, that it was 50% completely normal ECG. For me, it needs some thing. And also, 30% of the patient has non-ischemic heart failure, 70% are ischemic. I think this need more investigations and re-evaluation for microvascular, how to define the ischemic heart disease in the presence of microvascular dysfunction. This needs something. This is the other. Last question for Dr. Mirvat. From your knowledge, that to me, most of the meta-analysis of the left mainstem intervention show that the preferability or superiority or toward the DK crush. Do you agree with this or not? Thank you.
So, well, no. I think the majority of trials do recommend a provisional strategy as the default strategy for left main. So, so otherwise DK crush, simply because there are more trials that were done in that space. When you look at culotte, for example, the number of randomized trials that were actually performed are quite limited. As I showed you, the TAP, unfortunately, was done as a bailout. So most of the data that we have, the evidence that we have for TAP is bailout, but not an upfront strategy, which is too bad that it hasn't been done.
Regarding the
Last
other
question,
questions, I will do it. I'll do it very
Last
quickly.
comment.
It's hard, 40%, not 50% with normal EKG. We can talk about it when we go out because time is running.
1 minute, you can.
Okay with that?
1 minute.
Carry,
Okay.
carry.
Yeah, so it was 40% with normal EKG. I'm glad you pointed this out. In terms of ischemic versus non-ischemic, I think what the data which we have from Jordan, actually it's close to what they have from all over the world, including the States and Europe, that 2/3 are ischemic origin. Microvascular disease, I agree, but microvascular disease, you and I know that's not an easy task to diagnose and include in a registry like that. It's a beautiful thing. Thank you.
And if I want to tell you, there is a large
Okay,
data coming
Amr.
from Germany and Japan. It's about 8,000 patients on de novo DCB. And
Amr, let us finish. Thank you all. Thank you for your presence. Thank you.